Hi, I'm Dr. Moshrefi. I'm a periodontist practicing in Beverly Hills, California, and I'm a graduate from the University of Southern California Dental School, as well as their specialty program in periodontics. I've been practicing in Beverly Hills for approximately 15 years. The scope of my practice involves treating patients who have gum disease, have issues with their soft tissue as it relates to their mouth, want to replace missing teeth, and a big part of my practice is replacing missing teeth with dental implants. I'd like to spend a few moments discussing a new and exciting treatment option for patients who want to replace missing teeth. The first dental implants were actually placed thousands of years ago during ancient Egyptian times. However, modern implantology as we know it today really evolved in the last 50 years or so. The way we place the implants, where we place them, and their structure, how they're made and what shape the implants are manufactured in has evolved immensely during this time period. Well, currently most implants are made of titanium and they consist of parts that interlock within one another. Well, for decades, implants have been made out of titanium. Part of this has been that we've now placed these implants in so many patients that we found that there are patients with sensitivities to these implants because of the volume of patients who've now undergone this sort of treatment and the time that has passed. Well, ceramic implants can have several advantages over their titanium counterparts, and not all of it necessarily has to do with the sensitivity component. It is a very important part of this in that the implants are made of ceramic material, they are metal-free, and in the fact that they don't corrode or have the same sort of sensitivity issues in patients who may have metal allergies or may have inflammatory conditions which predispose them to having an inflammatory reaction to something like a metal in their mouth. But beyond that, really, for example, the implants are one piece. They don't have multiple components like the titanium implants that fit into one another. Therefore, there's very little to no risk of parts loosening because the implant is designed as a one piece. Furthermore, because of this, there's no micro gap at the bone level where bacteria can proliferate, as is the case with titanium implants where the abutment locks into the implant. In addition to this, the implants are white in color. Therefore, it's much more aesthetic, much more cosmetic. In cases where the soft tissue may be thin and you sometimes see a gray shadow or halo coming through the soft tissue due to the fact that the metal is showing through the gum tissue. Beyond that, I mean, there's so much more. Biologic with compatibility issues. Cement clean out is a non-issue, especially with CeraRoot implant design, because there's an implant for every specific tooth. Therefore, the top portion or the crown of the tooth is designed in such a way where cement retrieval and clean out is much more effective, much easier because the margin doesn't go below the gum line as far. Corrosion. I mean, there's no risk of corrosion with these implants because there is no metal. Oftentimes patients have many forms of restorations in their mouth because previously they may have had a filling done, a crown done, or bridge work done, and part of this is a substructure or framework that has metal in it. And the more metals of various kind there are in the mouth, the more this can contribute to what we call a galvanic effect and cause corrosion in the mouth. And corrosion really varies according to the pH of the mouth, the saliva content in terms of the temperature of the mouth, the fluoride that is in the person's diet or in the products that they're using. These sorts of things can all cause corrosion of the metal over time. And with ceramic implants, these are all non-issues. Absolutely. You know, ceramic implants are biologically inert. So in terms of their biocompatibility, they're ultra-biocompatible. And the bone-to-implant contact is just as good with ceramic implants in terms of their integration. So I have no issues or any concerns with placing ceramic implants as compared to titanium implants.
Feedback?
Sure, that's a great question. And actually, having placed thousands of titanium implants, and now, not nowhere near the same volume of ceramic implants, but I've seen enough where the first day or the second day after surgery, when patients come in for a quick post-op for us to clean some areas to make sure that they're doing okay, the soft tissue response around these implants is night and day compared to titanium implants. From day one, the tissue is pink. There isn't as much inflammation or bleeding when we go to clean these areas, or plaque retention. So yeah, the healing around these sites is significantly different compared to titanium implants in a good way. Now, in terms of placement and post-op, there has to be a paradigm shift in the way you think, actually, because it's not that it's different in terms of protocol. It's just there's a variation in the technique. It's much more technique sensitive in the fact that your placement has to be much more exact. And also in terms of the post-op, it's paramount that the patients follow certain instructions in order to ensure their success. One of those things being that you have to reduce the load or minimize the load on these implants due to the fact that they are one piece. So you have to fabricate a provisional that protects the head of the implant from any sort of tongue thrusting or loading from even chewing food. As much as patients try to chew on the opposing side or the opposite side post-operatively, it's inevitable that some food will get on the surgical area while they are chewing. So making an Essex or making some sort of fixed provisional that protects the head of the implant during the healing is paramount to success. This is actually the part that my restorative doctors love, because in terms of restoring these implants, it's as simple as restoring a natural tooth. There are no parts to fiddle with, no torquing to be done, no concern with parts coming loose in the future. The walls are so parallel that retention is excellent, and you don't need that much height in order to retain these restorations. So no, actually my restorative doctors prefer it, because if placed properly, there's very little to no difference in terms of restoring them compared to a natural tooth. Well, our typical post-op is that we'll see him at 1 week, we'll see him at 1 month, and then we'll see him at 3 months to prepare them for the restorative phase. Thereafter, we like to see him 3 months after the restoration is placed, and then once a year for implant maintenance and follow-up. Sure. In terms of doing immediate extraction and implant placement, that's nothing new. We've been doing it for a very long time. What is important though, what's critical is case selection. If there's any sort of significant infection, suppuration, bone loss, we tend to delay implant placement and follow the more traditional route and let the area heal, then go back into a healed site that's healthier, more receptive of implant placement. However, with that said, the good majority of our cases don't fall into that category. They are cases that we can go ahead and extract and place implants into. Where I tend to hesitate a bit is in terms of loading those implants with a provisional that's directly resting on the implant on the day of extraction. On the other hand, if it's an implant that's being placed into a healed site of many, many months, there's good primary stability. In that case, you can load the implant, with the understanding that the occlusion has to be taken into consideration as the patient's healing. Well, dental implantology is such that you're constantly learning. Each one patient is different from the one preceding it. But in terms of ceramic implants, it's critical to have not only a strong surgical background in placing implants, but also a really thorough understanding of where and how the final restoration is going to take shape and form. Because on the day of placement with the one-piece implant, that's as good as it's going to get in terms of positioning for the restorative doctor to put a crown on the implant. Well, while most patients are, there are some very important things to consider when treatment planning for a ceramic implant. The amount of bone available, the amount of soft tissue and the quality of the soft tissue that's available, the occlusion. These are all important factors to evaluate and consider before treatment planning someone for a ceramic implant. And success with these sorts of cases is much like any other treatment modality. Case selection, proper technique, proper follow-up care become very important in the success. Bone grafting is a common treatment option for patients who have undergone extraction. When the patient has a tooth extracted, the soft tissue, the bone in the area tends to remodel a bit during the healing process. And with the addition of a bone graft, it serves not only as a filler for the area, but also serves as a conductive material for the body to basically repair and replace the graft that is placed with the patient's own bone. Sometimes patients come in and at the onset they may not be a candidate for implant placement, but there are things that we can do like bone grafting, like soft tissue grafting, in order to get the area ready for implant placement. I always encourage patients to educate themselves, not only as far as what it is the doctor is proposing to provide for them as a treatment, but also on who is delivering the care. You want to go to someone who's qualified, who's comfortable providing the care that they're recommending, and also someone who is going to be available for you, before, during, and after the procedure, if you should need them. It's also important, I think, to have a doctor who includes you in the treatment planning process and respects your wishes and understands that the care that you might be seeking is not necessarily something that everybody may provide. But at the same time, they're open to providing new sorts of treatments which may be on the cutting edge, but at the same time have proven themselves in terms of efficacy and safety.
Very good.
So I know you've been traveling a lot, yes?
Yes, as
How's that
always.
been?
Fun.
I want to take a look at your implant. Are there any questions or concerns? It's been about a year since the crown has been put on.
Yes.
Are you chewing with it comfortably?
Yes.
Everything okay?
Everything's fine.
Okay, let me take a quick look inside. Don't mind bringing your head back for me. So we went through quite a bit. In the beginning, you had a big space between your two front teeth, and I remember you wanted that area closed. So it looks gorgeous. The soft tissue around the implant looks beautiful. Are you chewing with it comfortably?
Yes.
Okay, I'm just going to tap on it a few times, okay? From the outside first. Okay, sounds good. And also from the chewing surface. Looks good. No, it looks beautiful. It looks really, really nice. Alright, so Lupe, this is dating back to June of 2013 when we first met, when you first came in for your consultation. I'll just go over the x-rays or photos with you as we go along one by one. But basically on the left side here, you'll see the radiograph of that upper left lateral incisor right here. And around the apex of the root, there's a sizable lesion or shadow here that extends one tooth in front and one tooth behind. So what was going on was that you had a dead nerve, basically a necrotic nerve, with a resulting infection in the jawbone. And what we opted to do was to extract the tooth and graft the area, get it ready for an implant. We decided not to do this as an immediate implant for several reasons. One of them being the size of the infection that was there, And the second being that you expressed interest in treating some of the spacing that was present, that you can see in these photos, between those front teeth, so that your final result would be a little bit more aesthetic, okay? So to treatment plan in this case, we opted to do it in several phases. Number one was to get rid of the tooth and treat the infection. The second phase was to go ahead and close the gaps. And then finally to put the implant in, let it heal, and then restore it. So going forward, this picture on the left-hand side shows the area after the tooth was removed. You can see that we grafted bone. There was a slight flatness or slight concavity to the area. So in order to protect the bone graft and bulk the soft tissue up, we opted to do what's called a connective tissue graft, or take tissue from underneath the palate within your mouth and graft it on top of this to cover, build up, and protect the bone graft. And here you see the same view with the graft in place, again the facial. And then it was provisionalized in this case with a removable temporary. And we made sure that once the temporary was in, there was no blanching or pressure on that soft tissue to give it the time and space that it needs to kind of fill in that area. You can see from these photos also how minimal the incisions were. We didn't extend, we didn't place any vertical incisions. Therefore, there was no scarring which was going to take place as a result of the way we opened up the gum line here. And this shows basically at 1 month after the extraction how well this area is healed. Again, you see the spaces are still present because we haven't started moving the teeth yet. This would have been the next phase of treatment. So we opted to treat your case for the orthodontics with Invisalign. It took about a year as far as what I remember, is that correct?
I think it was a little over a year.
A little over a year. So this implant was placed closer to the final stages of the Invisalign when these teeth were in position. Therefore, it bought you a healing time in the fact that we used some of the finishing stages of the Invisalign to go ahead and allow the implant placement and healing time for the implant. So we gained a little bit of time in that sense. And 3 months after the implant placement or thereabouts, you can see how well the area has healed. The gum tissue here on the implant actually sits higher than the adjacent teeth and the contralateral tooth. So we've overbuilt it actually. Okay. So what happens at this point, or what happened at this point, is we went back in, we exposed the head of the implant so the restorative doctor could then go ahead and start shaping or molding the tissue with a provisional that was attached directly on top of the implant. Several months later, a final crown was made, and then it was delivered. These pictures are taken on the day of delivery. You see here an all ceramic crown on top of the implant analog. Okay, so this was chair side. The implant crown was then delivered onto the implant. You see here, and it's really important to note that there's a little bit of a black space here. Okay.
Why is that?
The soft tissue looks beautiful, but this black space is there because, even though we chose to shape it, it took, I think, 1.5 months, 2 months to shape the tissue with a provisional. Sometimes the tissue needs more time to fill in. And as long as we respect the proper profile and shape of the crown and give you a good contact distance from where the two crowns meet to where the soft tissue and bone is, studies have shown that that fills in. And if we go forward, we notice that this is the way you are today, about a year after.
Oh my gosh, so different.
So it looks beautiful. The soft tissue looks pink and healthy. That gap is completely filled, it's gone. The spaces between the teeth are closed. And your smile looks, looks gorgeous. Okay? And here's the before and the after profile. Again, you see how much of a diastema or gap you had, and that's completely closed here. Actually, preoperatively, there was a little bit of a black triangle, and it looks better in the final result than it did when we first started. And then here's your smile before on the top left, and after on the bottom.
Amazing. Wow, I can't believe it.
Yeah, it looks beautiful. I hope you're happy with it.
Very pleased. Oh my god, this is awesome just to see the before and after.
Very nice. I'm glad you're happy with that.
Very.